cells don't accumulate this protoporphyrin IX on this cells. So the same machinery, what I call the gluttony of the cells. We feed the cells for them to produce their own smart cells, to commit basically gastronomic suicide, I will call, where they get eventually, the sonodynamic therapy will kill the product of their own gluttony.
That is a very interesting approach because it makes treatment also much safer, right? Now, Dr. De Souza, one of the doctors using this approach is Dr. Mitchell Berger at UCSF Brain Tumor Center in San Francisco. He made a very interesting statement suggesting that the potential for this treatment, the treatment that you're developing, could turn glioblastoma from a lethal disease to a manageable chronic disease. If you draw a parallel with breast cancer, I think 30 to 40 years ago, metastatic breast cancer was very difficult to treat, and in most cases not really or hardly survivable. But things have changed, and metastatic breast cancer can be treated effectively. Is this something that you're trying to accomplish in the treatment of brain cancer?
Yeah, that's right. That's a great parallel that you draw over there from breast cancer. Dr. Berger, who's chair of our scientific advisory board, has stated is really our vision statement. We are still in clinical trials, but what we are doing to try and achieve that vision is to retreat patients. And that's what we've just started doing, is not just treat patients once, but to keep treating them to keep their tumor at bay. I'm under no illusion that we will have a cure, but if we can keep retreating patients to give patients a decent quality of life and turn them into survivors, that's certainly well worth doing.
In 2019, I interviewed a patient who, at the time, was a 25-year survivor of metastatic breast cancer. And today she is still a patient with metastatic breast cancer receiving treatment. But her health-related quality of life is okay, and she's able to be living a fulfilling life. Is that something that you're trying to accomplish in brain cancer?
That's right. I think the bar is high in recurrent glioblastoma, but as Ellie said, eventually, the right paradigm is to treat early. And maybe I'll turn it over to him here to add anything, since he has treated a lot of patients with these conditions.
Yeah, I think that in the case of GBM, it is true. It is especially patients who have recurrent disease. But one of the things that our therapy has the potential of really decrease the size of the tumor, correct? Not only keep the tumor from growing. And so the hope is that reducing the tumor will also improve the quality of life, because remember, a lot of these patients have some neurological symptoms that, they may have paralysis, they may have seizures, they may have weaknesses that may eventually get better after tumor reduction, correct? You can imagine a tumor growing around a bundle of nerves that serve a function and then having sort of a release. So the hope is not only make it chronic, but also improve the quality of life. And one of the things, though, a lot of therapies in recurrent diseases, they really make worse the quality of life, correct? So a lot of patients that go for second or third line therapies, their quality of life really gets affected. By the hand, if I may, we treat another type of cancer in children. And in children, I'm a pediatric oncologist by training. We really look more into curing disease than making it chronic, right? Because and if you see in general, pediatric cancers are curable compared to adult. And this is due to the biology of the tumors. Pediatric cancers in general, they grow very fast compared to the adults. And that's why prevention doesn't work very well in children, because they happen and grow very, very fast compared to, for example, a colorectal cancer that can be picked up by a colonoscopy, or a prostate cancer that start be taken out by PSA or a physical exam. So in pediatrics, in which we're already treating patients with the terrible brain tumor, we have the potential not only to make this tumor, control this tumor, but my hope as a pediatric oncology is really to have major tumor reduction with the potential on long-term survival. Patients with the IPG, most of them die in between 9.5 to 11 months. They only like 2 to 3% survive 2 years. So if we can start long-term survivals, it will be great with these patients. And I do think that any therapy that shows promise in the IPG has the potential of cure. Remember, we started treating monthly with these patients, so we expect more responses. And potentially there may be combinations in the future of different therapies that will help these pediatric patients. So as I said, in MRgFUS and GBM, the bar is very high, especially in recurrent GBM. And, we would love to make this a chronic disease. But in pediatrics, I will be a little bit more optimistic on the results that we eventually could have.
Let's take a short break, and then we're back with Dr. Eli Benaim and Dr. Mark De Souza.
My name is Jinhui Zhang. I'm the chair of a computational biology department at St. Jude Children's Research Hospital. As a data scientist, I feel so excited about seeing the potential impact, not only on the kids treated at St. Jude, but across the world. And I think this is a great use of the trust we got from our donors.
Finding cures, saving children. Learn more at stjude.org.
This is the Onco'Zine Brief with Peter Hofland.
And welcome back. In today's episode of the Onco'Zine Brief, I'm talking with Dr. Eli Benaim and Dr. Mark De Souza. I'm Peter Hofland, and this is the Onco'Zine Brief. Now, you've chosen to treat very difficult cancers like glioblastoma. But looking at your pipeline, I understand that you're trying to adapt the technology to many different forms of cancer, not only brain cancer. Dr. De Souza, tell me a little bit about this approach and where it may take you on the long run.
That's exactly right. We see sonodynamic therapy as a platform technology. We chose to start with these brain tumors, glioblastoma and diffuse intrinsic pontine glioma, the pediatric cancer, because we know they take up our drug, 5-ALA, in high amounts compared to normal cells. Indeed, an oral form of ALA is approved to image brain tumors, image high-grade gliomas prior to surgery. So we knew that the drug gets there. So we started there. We know from prior work from our scientific founder and others that a number of different carcinomas outside the brain take up 5-ALA similarly in high amounts. That includes conditions such as pancreatic carcinoma and others. So we have the potential to treat a number of different cancers outside the brain. And we're just in the stages of exploring sonodynamic therapy and working with key opinion leaders to prioritize these cancers outside the brain. So the idea is that we wish to prove the concept of sonodynamic therapy. And with Dr. Sinai's pioneering study, that was the first clinical study ever done in man with sonodynamic therapy. We plan to continue with our own studies in recurrent glioblastoma, in DIPG, and eventually in newly diagnosed glioblastoma, and then expand outside the brain into tumors such as pancreatic carcinoma and other cancers outside the brain to really prove that this is a platform.
So that makes it again very interesting in terms of potential of these treatment options. Dr. Benaim, can you tell me a little bit about the possibility of this platform and the treatment options beyond brain cancer?
I love when Mark, brought up, how to view this therapies. You have to understand when you treat in the brain, there are certain limitations, right? There's a skull. You have to go through some type of MRI machine, use the ultrasound. It's a little more complicated. There's some terrible diseases, and we pick very well because they do have a high uptake of 5-ALA. But when you go outside the brain, right? Imagine that now you're talking with in ultrasound that you handle by hand instead of an MRI. Right. So now this is where can we use this technology? Right? And so you say, well, ultrasound of the abdomen. Where can I treat this? I know where the pancreas is. I know how to treat it. Now that ultrasound technology is very advanced, it can differentiate millimeters of any organ anywhere in the body. So bladder cancer, correct? And this is eventually, there's no toxicity. We're talking here at a very low intensity ultrasound waves, like you do for a pregnant woman or an echocardiogram. So you can, the vision, if you want, the sci-fi vision, if you want, can you imagine giving IV 5-ALA and then going with your handheld ultrasound machine and going through different parts of the body and killing cells that have an increased uptake of 5-ALA, which will be the malignant cells and not the normal cells, right? So the potential of going almost in any organ in most types of cancer is incredible. So obviously we have to prove this. We have to prove it in the brain, and there is already some activity that works. But it is a platform where we have to go outside and try to treat cancers that, again, has a high uptake of ALA. This therapy has been used before. Right? The therapy has been used for skin cancers, where a cream has been placed on pre-malignant or malignant cells in the skin, and then a blue light has been given. If you go to dermatology offices, you probably have seen this blue light on a corner that you see there, and you get the blue light. So this therapy has been proven already outside the brain, and the one who did this was our founder, Stuart Marcus, that had that company that showed that. So we know this work outside the brain. We just now want to use it in other places. So our plans in the future is really to advance the platform in multiple types of cancer, and that's obviously we need the support of the community and the scientific community to really prioritize where to go. And we're going to go obviously where the patient, the therapy is needed the most. So obviously that's why we also go sometimes to the worst cancers like the IPG and GBM.
Well, this sounds not only futuristic, but very exciting, and brings hope for people that are diagnosed with cancer, even hard to treat cancers like glioblastoma. In conclusion, when you say that in the future there will be a handheld device doctors can use to treat patients, would this be potentially in a GP's office, or is this always the realm of an oncologist? What are you expecting?
I suspect the latter, actually, that this will still be in the realm of a specialist with each of the organs that we wind up treating.
Yeah, I agree, but we're not that far away to having that device to be in the oncologist's office or the urologist's office. So that's not that far away. We're already in the process of looking into having that device and conduct clinical trials in that. But eventually, we hope that to have really a futuristic therapy that will not have side effects, that will be easier to give, and that could be repeated until the treatment is effective, and that will have low risk for recurrence, right? For having resistance to the therapy. One more thing that I would like to see on this therapy, correct? It is that even though we know how to give it, and eventually there will be very strict parameters on how to, these ultrasound waves get to the tumor, each patient will receive a very personalized therapy, because this therapy will be, this ultrasound will be tailored every therapy to the characteristics and the size and the response of the tumor, which is different than getting, for example, radiation therapy, where you're still going to get radiation. Maybe you'll move, there's some response. Maybe the area where it's going to be treated with the radiation will be a little different, but the patient will get the same amount of radiation. Or if you're getting chemotherapy and there's response of the chemotherapy, you're not going to change the dose of the chemotherapy. You're going to still be given the same dose. In our case, we personalize it to the response